Today's topic is a really good one. This is about reviving the heart of healthcare, the joy of practicing family medicine. You remember the old MasterCard ads, where you have to do this and it costs X amount of money and then you get a MasterCard and it's priceless. So for me, family medicine is like having a MasterCard. I'm a family doctor. I'm a proud family doctor. In fact, miss practicing family medicine since I became dean here. But indeed, family medicine is such a wonderful specialty, and we'll have a wonderful program for you today. And I hope you will participate in rekindling the love of family medicine. Next slide. What a turnout we have today, and this is just half of the turnout. We have quite a few high-level, nationally renowned speakers, Dr. Green, Dr. Kumanan, Dr. Newberry, Dr. Moyer, Dr. McClendon, and 3 resident representatives who will be introduced to you later on. And I really hope that you will enjoy this session. Next slide. And that was the housekeeping slide, so we'll go to the next one, please. I'm here in Sudbury on the traditional lands of Wanapitei and Atikameksheng First Nation. Our other campus is in Thunder Bay on Fort William First Nation. Beyond a land acknowledgement, for us at NOSM University, truth and reconciliation is in our DNA. We gratefully acknowledge the elders and the knowledge keepers who share their gifts and teachings with us. In fact, that is one of the characteristics that makes NOSM University so unique in this country. We have a deep commitment to our pan-northern campus that is all over the 800,000 square kilometers at the complete respectful and being guests of the First Nations and Métis people. Wherever you are today, please reflect on where you are and the legacy of being a guest on these lands. Next slide. So as I said, the President's Lecture Series started when I got here in 2019, and we've had 4 sessions. The first one was on mental health and fighting stigma. The second was on racism in medicine. The third was on planetary health and environmental accountability. And last year it was actually on how to choose your residency match. The goal is really to speak to medical students around the country and mostly at NOSM University, at least in 3rd year, where they're starting to make decisions about their future. The practice of family medicine in Canada has been seen as being in crisis for the past few years. And so our objective today is to showcase why family medicine continues to be a career worth choosing, to explore the challenges, and to highlight more than ever in Canada and in Northern Ontario that we think family medicine is a specialty that you should choose. And I'm just going to stay there for a minute, Chantal. The data has shown that in 2022 it was around 31% of graduating students that chose family medicine. In fact, the high point was in 2015, where almost 40% of students chose family medicine as a career. Interestingly enough, at NOSM University, it's close to 50% of our graduates. However, nationally, the choice of family medicine has dropped quite significantly, and as I've shown, about 30% of students are choosing family medicine. So that is a challenge, especially since we need more family doctors. In Canada, about 7 million people do not have a family doctor. And in Ontario, it's close to 2.5 million people. By 2026, that's going to get closer to 4.5 million people. So this is a challenge. We think that talking about the joy of family medicine and embracing the challenges and the problems, but recognizing that those of us who chose the career is really worth the dialogue, because there is the joy of the breadth and the depth and the wonderfulness of being a family doctor. My story is that I was an older student. I practiced law. When I went into medicine, I did my residency at Queen's University, a fantastic program. I did a 3rd year, in fact, in care of the elderly. But when I was leaving Kingston to go to another job, I had been in practice for 15 years and I had delivered babies. I did obstetrics and palliative care, the whole life cycle. And when I was leaving, I had a 15-year-old who jumped up on the bed to come say goodbye to me and jumped onto the examining table and said, "But Dr. Verma, you're the only doctor I've ever known." And that was probably the hardest moment for me, recognizing that I had delivered him as a baby and now he was 15 years old. That's family medicine. So we're going to go to the next slide, which is, I want to thank the entire team of our NOSM University Student Council, but in particularly Julie Leroux, the president, Kaylee Bourdon, our VP's Communications Senior, and Dev Patel, our VP Global Health Junior. All three of them have done a fantastic job, and you'll see bits of them as we go through the day, the evening, sorry. And in fact, in the next moment, I will be handing over to Kaylee, in fact, to have her introduce the agenda of the evening, and then she'll hand over to Julie. But thank you, Julie, Kaylee, and Dev, for your brilliance in picking this topic, helping us find the speakers, and helping us run it. Kaylee, over to you.
Awesome. Thank you so much, Dr. Verma. So I'd like to introduce you all to our agenda for the evening. First, we'll be hearing from Dr. Green, who will discuss family medicine from the perspective of the Canadian College of Family Physicians. Then Dr. Kuminen from the Ontario College will speak about family doctors as health advocacy leaders. After a short break, we'll get the family physician's perspective from Doctors Moyer, Newberry, and McLinden. And finally, we'll hear from residents in family medicine, Doctors Mansour, Bourdon, and Gillisy. To wrap up the evening, we'll have an open forum discussion where participants can pose their questions via the WebEx chat. And then we'll wrap things up. So I'll hand over now to Julie.
Hi, so it's my pleasure to introduce our first speaker of the evening, and this is Dr. Michael Green. A little bit of background, Dr. Green completed his medical degree at UBC and did his residency in family medicine, of course, at the Memorial University of Newfoundland. He practiced for 8 years in Moose Factory, Ontario, and then completed a Master of Public Health with a focus on health policy and management. In 2003, Dr. Green started practicing in Kingston, Ontario, and he served as a medical officer with Indigenous Services Canada's First Nations and Inuit Health Branch from 2003 to 2014. Dr. Green is the current president of the College of Family Physicians of Canada and an experienced family physician, educator, and researcher with a passion for improving healthcare. So I'll pass it over now to Dr. Michael Green. Thanks.
Thank you. And Chantel, can I have control of the slides? Well, I'm seeing if that will come up. If not, I'll tell her when I want to advance. Thanks, everybody, for having me. Bonsoir à toutes et tous. I'm joining you from here in Kingston, traditional Haudenosaunee and Anishinaabe territory. And you would have seen that my journey here brought me through Moose Factory, the Mushkegowuk Cree territory where I was for many years. Don't seem to have control. So can I have the next slide, please, Chantel? So I'm going to talk a little bit about why family medicine. And Dr. Verma asked me to speak a little to why is family medicine a specialty? How is it different from some of the other specialties? And also I'll share a little bit about my own journey and decision points across the course of my career, hopefully to help you see that family medicine is super flexible, fantastic, and really offers opportunity for growth over the course of your career. I'll take the next slide, please. So family physicians are the backbone of Canada's healthcare system. We're the regular healthcare provider for 19 out of 20 Canadians who have a regular primary care provider. So although we hear a lot about other primary care providers, and they're super important in our teams, the backbone of primary care is still family physicians. And family physicians provide 52% of all medical services in Canada. So not just primary care services, but all medical services in Canada, over half. Next slide, please. And we know that having a family physician, regular source of primary care, lowers the risk of rehospitalizations and emergency department use for all sorts of different populations. Patients in the general population, patients with severe and non-severe mental illness, patients on home care, patients with dementia, patients with diabetes. Doesn't matter how you slice and dice it. having access to a family physician improves your outcomes in the long run. Next slide. Family physicians are licensed as family medicine specialists. So I'm going to talk a bit about this. Longitudinal care, which is about 70% of what family docs do across the country, is a major component, but it's not everything. And they provide care in a variety of settings. And I know I was super excited to see the panel of docs from Northern Ontario that's coming up later. They are a great example of the range of settings and types of work that family docs can do. And I know that many of you as students would have had a chance to get some exposure to this already. But it is important that we think about comprehensive longitudinal practice, because that's something that's unique to family medicine. It's not something that the other specialties do. So, pediatrics will provide that for kids to a certain age. In geriatrics, you might have that at the certain, for certain seniors, but really family medicine is the only specialty that comprehensively follows people from birth to death along the lifespan. And that gives us a very unique perspective on people's healthcare, their healthcare needs. And it requires us to define our specialty and our knowledge base that goes with that for ourselves. Next slide, please. So what do we do besides those longitudinal things? If you look at hospital-based assessments, almost half of all hospital-based assessments in Canada done by family doctors, just under half of all psychotherapy and counseling services, about half of surgical assistants, and around a third of all non-cesarean section obstetrical deliveries. So Dr. Verma commented on doing obstetrics, which I included in my practice for quite a while also. Still a real important part of obstetrical delivery service in Canada. Next slide. So I'm going to talk a little bit about our standards and frameworks and how they may differ a little bit from other specialties. So the College of Family Physicians has a family medicine specialty committee that does all the academic stuff on defining what it means to be a family doctor and the competencies and entrustable professional activities, all the education slang words that we have for what it means. But what it really means is, what does it take to be a family medicine specialist? What are the core things that we need to know? And they are different from those in other medical and surgical specialties. Many are similar and can map onto a similar framework, but what they are is unique. So we'll go to the next slide. And you can see that a little bit even in our frameworks that we use. So as a medical student, you're probably always getting evaluated on the CanMeds frameworks. And yeah, to the right, you see the one that was that's used for specialty care. And then on the other side, the one that looks more like a tree is the CanMeds family medicine. And what you see is, although the leaves of the tree are similar to those the other thing always reminds me of like an atom or a nucleus with a little nucleus of medical expert in the center, is that we've got the leaves on the tree, and it's the trunks that are rooted that are significantly different and not considered in the same way in other specialties. And that is that family medicine is a community-based discipline where you're providing service to a defined population, and you're a skilled clinician, but you also are bringing that population health perspective, and the patient-physician relationship is central to everything that we do. It's the secret sauce. The longitudinal continuity of care that you have with your patients is the secret sauce of family medicine. There are some new frameworks coming, so they've heard great questions. How come our tree is floating around in the air? What roots it? So some of those topics that were on the President Lecture Series before, global health, anti-racism, those things need to be, those I think are parts of what's in the ground at the roots and the social determinants. Next slide, please. So what is family medicine? I'm going to talk a bit about the comprehensive medical care. So that includes primary care, emergency care, home and long-term care, and hospital care. And because it's undifferentiated populations, the key things that we're looking at are learning to be uncomfortable with uncertainty, learning how to identify a problem from the very beginning of a vague symptom through to the development of a diagnosis. I've got a column in CFP every month as the President's Corner. And the one I have coming up in next month's issue is going to be on research and the importance of understanding that the patients we see in family medicine in community, living their lives in their context, our experience of that as family doctors is very different from the experience of specialists seeing people with a single condition, often very not inside their local context. And so our whole understanding and knowledge base and research that's the basis for our specialty is grounded in family medicine research that helps us understand patients where they're at. Importantly also are though leadership, advocacy, and scholarship. Those are big parts of your journey through your career besides being an expert clinician. And I just want to talk a little bit about how that, for me, looking at medical care, leadership, advocacy, and scholarship has developed over the course of my career and kept me as an engaged, excited, proud family doctor. Because I've been through many stages and made a few changes over my life and the direction for my career. And I thought it might help as you're preparing to decide, is family medicine the right specialty for you? What it looks like through a different lens at different stages of life. So next slide, please. So I'm going to talk, I'm going to talk about a few places in the world. Family medicine has been amazing for me. It's brought me lots of different places to practice medicine as well as for research. And some of the spots I have on this slide, I'm going to talk about specifically. I'm going to talk about Vancouver, where I started as a learner in medical school. I'm going to talk about Newfoundland, where I was a resident. I'm going to talk about Moose Factory, where I started my early career. I'm going to talk about a mid-career pivot and going back to school in the United States, moving to Kingston, and then some of the global health experiences that I've had both clinically and through my research. Next slide, please. So I looked a little younger then. You'll see me in a couple of these pictures, one with a couple of my colleagues graduating from medical school at UBC in 1993. It was very different back then. I really actually think you guys are so lucky that you've got the Northern Ontario School of Medicine as a place to start your undergrad experience. I did my undergrad in Vancouver at a subspecialized hospital where there was not even one day of family medicine clerkship. My sole family medicine experience and exposure to family medicine was a course on communications in the first year of my practice. So I had to seek out I got clinical experiences almost exclusively in hospitals. I got some global health experience. I went to Papua New Guinea, spent some time in the Southern Highlands of in Mendi doing research on HIV prevention. It was in the very early years of the AIDS epidemic. That was my entry into scholarship as a student doing a student research project. I did have the opportunity to get some leadership opportunities with my student council, so the Medical Undergraduate Society, and I really thank the students for organizing this. Student leadership's a great place to get your foot in and start to learn about that. And my advocacy was mainly in the area of global health. That's what I was interested in as a student. And so you'll see that in my first early parts of my career, that's where it was taking me. I'll go to the next slide. As a resident, when I was finishing, so I noticed Dr. Verma was talking about the match in 2015 as a peak for family medicine. But actually, if you go way back in time, 1993, when I graduated, was when there was a full conversion from internships to residency programs. And I think it was about 55 or 60% of people who had not yet figured out that there was a thing, had to make a decision for the CARMS match heading into family medicine. So for sure, for me, I still had the option. I could have stayed in BC and done an internship, but I explicitly chose a family medicine residency because I really had not had any opportunity clinically to have that exposure to family doctors in their offices. I had Carol Herbert, who was head of family medicine at UBC when I was there, went on to become dean at Western, was a great mentor, but she just wasn't given the opportunity to have students enough to give us all an exposure. So I had little bits that I sought out on my own as a student, but residency was my first real exposure to in-office family medicine. And I loved it. At first, I was thinking, should I do global health, policy, more research earlier in my career? But my experience as a resident and the love for clinical medicine in family medicine convinced me that I needed to start my career as a clinician. It also reinforced the importance for me of working in a community that needed me as a health professional, where I could have an opportunity to try out my leadership skills further. And so as a resident, I carried on in resident politics as the president of the residents and interns in Newfoundland. But I also continued my interest in global health. And the photo of me on the road there is from a 2-month elective that I spent in Uganda. Again, this was the peak early days of the AIDS epidemic. So really learning a lot about HIV care and working in a low resource setting prior to coming back. Also a chance to see the joy of rural medicine. I'm a big city kid. I'm from Vancouver, and going to Memorial gave me a chance to see rural medicine and all the opportunity that offered in in not just clinical practice, also I'd say in leadership, advocacy, and scholarship, because, as a rural family doc, you're not in a hospital of hundreds and hundreds of people. You do have to step up and play those roles as well. So me and my friends from BC who are in this picture, we're all BC medical students who went to Newfoundland for our residency. And I have to say it was a fantastic decision. Next slide, please. NOSM didn't exist, by the way, so I'm not dissing NOSM. It's just at the time there was Family Medicine North and NORFAM as residency programs without the whole structure of NOSM around it. When I finished, I was encouraged to consider going to the North, and I'll credit one of my early mentors, Dr. Sherry Bethune, former president of our college as well, who was the head of department in family medicine when I was a resident, who had spent time in Moose Factory. And she said, you should check it out. So I went off as a resident in my Christmas, New Year's break for a job interview, took the job in Moose Factory, and went up on what was first a 1-year contract. Ended up being there for 8 years. The clinical breadth was incredible. Hospital, emerge, obstetrics, a lot of air ambulance, traveling my community. So you can see me getting ready to hop on Air Quebec. Just for reference, something you don't see anymore, those the thing under my arm that's in a kind of paper colored thing are x-rays. Actual printed x-ray films that I had to bring with me on the plane to Saskatchewan, which was the community that I traveled to most of the time to deliver care. Because even in the North, continuity of care is so important in family medicine. One thing I certainly learned there is that no matter what your setting is, no matter how low resource or how high resource, that continuity of care is a critical part of being able to be an effective family physician for a community. And so I knew I had to be curious. I was like, why can't people follow any of the recommendations that are being made sometimes in the clinic? So I did a house call, and you can see that house there. That house is the exterior of a house that had 15 people living in it. And you can imagine the difficulty that people would face in carrying out some aspects of their treatment plans if that's their context. It was also a chance to learn about the importance of teams. I've always worked in a team. Our team of family docs there, it took some time to try and get out on the land and learn about Indigenous culture while we were there. We were really fortunate to have Moose Cree First Nation lead some opportunities for us to get out on the land and see what it was all about. Even learn a little bit of Cree. So there was always a chance for learning. It was also where I became a teacher and had the opportunity to teach. So I know that that's such important work your preceptors do, and this was my first exposure to being able to do that in the setting in the North. But it was still early, mostly focused on clinical for me at that point in my career. Go to the next slide. After about 5 years in Moose Factory, I still was really enjoying the work, but I was really seeing the social determinants of health and that community-based pillar of what was required, and thinking I needed to learn more to be more effective, because I thought that leadership, advocacy, and scholarship would be able to be more impactful than one-on-one care all the time. So I headed off back to graduate school at Johns Hopkins. I flew back and forth between Moose Factory and Baltimore, spent 3 summers in Baltimore working on my degree while I was working full-time in Moose Factory as chief of staff. My oldest daughter had her first 3 birthdays down there. But that really opened doors for me to consider a change. And so at the end of that, I ended up coming to Queen's University, which has been fantastic. As Dr. Verma said, another great family medicine program. Our Train at Queen's Work Anywhere slogan, really important focus on generalism and being adaptable for different areas. But the training, the research training, allowed me to take more of a role as a clinician scholar and start to work on building that evidence base for family medicine. The group photo that's there for me is a group I was involved in called Educating for Equity. And certainly one thing I learned a lot of in Moose Factory was the importance of addressing the impacts of colonization and all of the pieces of the journey towards reconciliation that are in the TRC. And so I've been privileged to be a part of a group that's done a lot of work on particularly diabetes care for Indigenous patients, led by Dr. Lindsay Croshu from Calgary. And that's a shot of our team at MRI in Auckland with our colleagues in Australia and New Zealand, who also are dealing with many of the same things. But this is the teamwork again, team in research, team in clinical care, that brings us together to advance our discipline. Next slide. That brings me to where I am today. So now people start to call me senior. People who I'm used to being called. I prefer to be called Mike most of the time, but people now want to call me Dr. Green. I'm really privileged to lead the college this year. Our college is an important home for us as a profession in so many different ways, whether it's our member interest groups or our academic family medicine groups that are working on advancing our educational mandates, or just people who are supporting the ongoing clinical education and professional development for all of our 43,000 members across the country. And I've moved to a place, I had to give up intrapartum obstetrics about a year ago after 26 years. I kept it up as long as I could in this setting, but I was sometimes the leadership work takes you away from the clinic day to day too much. And there's new opportunities to develop things. So I'm actually really excited. The group photo there is from our Ontario Health Team leadership team, and people may have seen the announcement today from Ontario government about new teams, including a new interdisciplinary primary care model we're going to try out here in Kingston called the Periwinkle Clinic. And this, being a part of this leadership team with our Ontario Health Team, has given us the opportunity to think about how to do that differently and how to try and address some of those crisis in family medicine points here locally. It's also really given me a chance to go places I never thought I would. So the Penguins are from the Falkland Islands, where our residency program actually offers a remote family medicine core residency rotation for 2 months, where people can go and do that 2 months of core rural family medicine that we require of all of our residents down in the Falkland Islands. And I had the opportunity to go down and check that out. Very interesting place, showing me once again the importance of social determinants of health and investment in the healthcare system, what you can do in a remote location if your government's committed to providing you the resources that you need. That'd be an interesting talk, separate talk sometimes, Sarita, but it's really interesting how different it is from some of our most remote communities, and it's all about government's commitment to providing people their services. And I would be remiss if I didn't thank my wife, Martina, for putting up with me with all of this medical clinical leadership stuff that I've been doing all the way along the way that frequently takes me away from home. I'm going to go and I'm not done. So what I really see now is this is the beginning of my senior part of my career. It is a time to step back and really provide not always at the front end of the scholarship of trying to lead a project, but trying to step back and help others grow into their roles and mentor the kind of mid-career and junior folks who are coming after. Next slide. So I do want to, I'm gonna try to do a little bit here of a segue into Dr. Kuminen's presentation, because I didn't get to talk much about advocacy, and that's going to be her focus, which is great. That is the other amazing thing about family medicine, is we make a difference. So we actually know a lot of the things when people talk about crisis in family medicine, the research has been done. Like, our colleagues have come up with great ways and great ideas for how we can improve things. And we've got those summarized for government. It's really a matter of implementation, more so than not knowing what are the right things that we need to do. And I'm going to leave the discussion about Ontario-specific advocacy to Dr. Kuminen. And I think that brings me to the last slide, which is team-based care. And I really did want to mention this because I know people worry sometimes about the future of family medicine and the future of family doctors when they're talking about team-based primary care, and, you know, our pharmacists or nurse practitioners or others going to take our jobs. So there's a lot of that sort of turf sort of stuff that goes on. There's room for everybody in the medical home. There's a lot of need for us to meet that's unmet, as was mentioned by Dr. Verma at the beginning of the talk. The College of Family Physicians has this model of patient's medical home, which has been adapted in many, many different provinces and many different settings. It's not the same everywhere. It'll be, you know, different in Moose Factory and Thunder Bay and Sudbury than it is in Kingston or downtown Toronto or another province. But this model of care makes a difference. I've always practiced in a patient's medical home my whole career. That has sustained me. When people ask me, how do you not burn out with all of those things that are going on in all the crisis in family medicine? It's being a part of a patient's medical home, having the team around me, having the right infrastructure to support me, and knowing that then you have the resources to help your patients, because it's the moral injury of not being able to help your patients when you know that's what you were meant to do in your career as a family doctor, that really drags people down. And I'm pleased to see that this is really taking off across the country. So PEI just announced a whole focus on developing patients' medical homes across the province there, and people may have seen an announcement earlier today from our province around some investments in team-based care. It's not enough to get us to everybody, but if I were you, I would be looking for a great career in family medicine, working in a patient's medical home. Thank you.
Thank you so much, Dr. Green, for sharing your journey and also showcasing not only the breadth, but also the depth of family medicine. I really appreciate it. I'm also really excited to introduce our next speaker, who is Dr. Mahalai Kuminen. She completed her undergraduate studies, her Master of Health Administration degree, and medical school at Dalhousie University, and then completed her residency at the University of Western Ontario. Since 2008, she has served the community of Cambridge, Ontario as a family physician with Two Rivers Family Health Team. She's also the current Chief of Family and Community Medicine at the Cambridge Memorial Hospital. She has served as an OCFP board member since 2016 and was installed as the 64th president of the OCFP in September of 2022. Dr. Kuminen, thank you so much. I'll pass it off to you.
Thank you, Julie, for that really nice introduction. I'll just say I'm really excited to be here today. I'm joining in today from Kitchener, the traditional territories of the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. And I'm excited to be here to talk to you both about family medicine and also about family physicians as health advocates. I think Mike helped to segue really nicely without really stealing my thunder, so thank you for that. Okay, next slide, please. So I'll start by just telling you a little bit about the Ontario College of Family Physicians. Mike touched on sort of his role as the president of the National College, and we are essentially a chapter of the National College. Our role is to support the 15,000 plus family physicians across Ontario. And you'll see in our mission that we try to do that in a number of different ways through education, leadership, research, and advocacy. Next slide, please. I wanted to actually just start with a little bit of a patient story, and I'm going to link back to this one, but I hope it will set the stage for what we're talking about today, and also sort of paint a picture for some of the joy that we get to enjoy in family medicine. Now, this is a sad story. It's a patient of mine who was in his 70s a few years ago and was having a fair amount of abdominal pain that seemed to just be progressively worsening, and we weren't really getting to the bottom of it. And it was during a really tough time in the pandemic, when patients were struggling, I think, to kind of know when to come in and when not to come in, and not always wanting to come into the healthcare system. And it was also really hard to access investigations at times. So for this patient, I eventually, as his pain worsened and we weren't really kind of getting anywhere and he was getting sicker, we eventually got a CAT scan of his abdomen. And I happened to be going through my inbox at the end of a clinic day at home and got his results. And I knew that both he and his wife would have wanted to know the results fairly soon. And this is partly just because I had worked with him for so long that I kind of knew that he was really anticipating getting a call from me. Unfortunately, when I got his results in, they were really concerning, and it essentially looked like he had a metastatic cancer. So I felt really horrible. I knew this patient well. I knew he wanted the results, but I really was quite sad to see the results and to have to give him a call. So I did give him a call. He and his wife were both on the phone, and I think after I reviewed the results with him, I just said, look, I'm so sorry that I have to be breaking this news to you. And I think what stood out to me with this patient's story was just his response. I guess I went into it really not knowing what to expect, despite having done this many times before. But he just actually paused and said, it's okay. I'm just glad it's you giving me this news. And I think for me, what stood out was in that moment, despite him receiving probably the worst news of his life, he somehow was able to appreciate how valuable it was for us to have that patient-physician relationship, and how it seemed to help him somehow, despite him receiving bad news at the time. So I'm going to loop back to that story, but I wanted to start with that, and maybe I'll just ask for the next slide, please. Okay, so I know Mike touched on this a bit, sort of the joy of being a comprehensive family physician. And I think I won't go through this slide in detail, but I think just that idea of that relationship-based care that I just outlined in that patient story, I think makes such a difference to the care that we provide, and we know really brings value to the care that we provide. For me, in terms of why I chose family medicine, I have maybe a bit of a different path than some may have. I had wanted to do pediatrics for a very long time. Long before med school, and then all through med school for the first several years, that was my goal. And I stacked my electives with pediatric rotations and was fairly headstrong about it, to be honest. Sometime in my third year, I had a geriatrics rotation. And in all honesty, I was a little confused because I thought, like, everyone knows I want to do peds. Why am I getting a geriatrics rotation? But went into it with, I think, a positive attitude, and really I think it just made me realize how much I loved adult medicine as well. And how I didn't want to give that up. And so it really made family medicine seem like the perfect fit, where I knew I could care for kids and have that community-based practice with a lot of young children in it, but also be able to care for adults and people throughout different stages of life. And I will say, I think it is part of that comprehensiveness that just brings joy to what we do as family physicians. Okay, next slide, please. So I know that we will probably talk about this. I think Mike already talked about it, but I wanted to just hold here and really talk about why it's important to have comprehensive family medicine in our community. And I think what stands out to me so much is how much data and evidence we have to support ensuring that our patients in the community can access care from a family physician who knows them and has gotten to know their health issues over time. I won't go through these one by one, but I think it is pretty impressive when you look at just by virtue of having more family physicians in the community and more patients attached to family physicians, we know that we make such a big difference, both in terms of patient health outcomes, but also in terms of sort of overall system usage and lowering cost to the system. Next slide, please. Okay, so I'm going to shift gears a little bit. I wanted to just briefly give an overview of some of what's happening or has happened in primary care in Ontario, just to set the stage for the advocacy part of my talk. Next slide, please. So just going back in time, some of you may know this, in the early 2000s in Ontario, we started to see a movement away from fee-for-service, as well as a movement towards alternate payment models. So in 2005, along with those changes, we saw the Liberal government funded the first family health teams, and many of you are probably familiar with family health teams, where we have family physicians who then work with other health professionals, all to support the patients in that practice. Over the decade between 2000 and 2010, we then saw quite a significant shift away from almost exclusive fee-for-service, so about 98% in 2000, to just over 35% of family physicians being paid fee-for-service. Next slide, please. And I'll just quickly go through a little bit on our compensation models, because I think it does tie into some of the advocacy as well. So in Ontario now, I'd say we could say we have about 3 predominant compensation models. Fee-for-service is the first, and I think that's essentially where physicians are billing based on the services they're providing. Now, as I mentioned, we have seen decreasing numbers of family physicians in comprehensive care billing fee-for-service. The next category is essentially our enhanced fee-for-service models, and this is where that alphabet soup starts to come in. So you've probably heard of family health groups. And for family health groups, essentially the majority of those physicians will bill fee-for-service, but this is essentially a patient enrollment model where there are special bonuses and premiums for chronic disease management and preventative care. And then the next category is essentially our blended models. These are currently our most common patient enrollment models. And this is where we see family health networks or FINs and family health organizations. In these cases, physicians are paid a capitation payment, or the bulk of our payment comes from a capitation payment. And the idea is then we are assigned a group of patients to care for those patients. And there are also the additional bonuses and premiums for delivering preventative care and chronic disease management. And so today in Ontario, we have about 39% of family physicians working in a blended payment model. And then we know there are other models like salaried positions through community health centers. And I will just say, I think generally we are seeing continued shifts, not just in Ontario, but in other provinces as well, towards more capitation-based payment in family medicine. Okay, next slide, please. So I wanted to touch a little bit on some of the challenges that we're facing in family medicine, and I will then shift to talking about some of the solutions that we have. So we know with our patient enrollment models, they did have a positive impact in terms of increasing the family physician workforce fairly significantly. And also we saw sort of increased satisfaction in terms of patient satisfaction. However, we know there have been ongoing issues in family medicine, and I'll outline those. So I think the first is really just inequitable access to care. We know in Ontario, we have about 2.3 million people who don't have a family physician, and our forecasting shows that number is expected to grow to 4.4 million by 2026 if we don't take action. We also see inequitable access to team-based care. Currently, we have about 70% of family physicians who are not working in a team-based care model, although we did get a new announcement today, and I'll come back to that. And, you know, this is all happening at a time when our population is aging. We know patients are presenting with more complex medical issues. And ultimately, as much as it makes for really interesting medicine, it takes more of our time as family physicians. And then the final point is just the administrative burden that family physicians face. And this is an issue for a number of reasons. I think it pulls us away from being able to have the time that we want to spend with our patients. But we also know that it can really contribute to burnout. And what we've seen from our member research through the OCFP is that family doctors in Ontario spend about 19 hours per week dealing with administrative work. And at a time when we are really trying to increase capacity in family medicine, we know that this is a really important number for us to get down so that we can free up some of those hours. Okay, next slide, please. So I don't like talking about the challenges without touching on solutions, and we certainly do have solutions that we know can make a difference. And I think this really connects to why it's so important for us as family physicians to really think about advocacy work, because we bring such an important lens to the healthcare system and to advocacy. So in terms of some of the solutions to address the challenges, I think the first would be looking at teams. The second is looking at the administrative burden. And finally, we want to look at how we compensate family physicians in order to keep pace with inflation. And I'll go through those one by one. Next slide, please. So I won't go into this in too much detail, but really we know that team-based care is a really effective way to provide care to patients, particularly those who have complex chronic medical issues. It's a really nice way, like Mike said, to bring everyone into the fold where we're all working together to support the patients in a community. And it can be a way to increase capacity in primary care, partly by increasing access for our patients, where they would essentially see the right person at the right time, and that's not always going to be the family physician. Okay, next slide. The administrative burden. So I've touched on this a little bit, and I think what I'll say here is just, we know that there are a number of things that contribute to the amount of admin work that family physicians are facing. I think it's a really complex issue. There are clear strategies and solutions that we can use to address that burden. And it's really going to take a multi-pronged approach. We know, as one example, that referrals right now are quite challenging for family physicians. I think, especially in the context of the healthcare system being fairly backlogged, often family docs can spend quite a bit of time just sort of trying to get our patient the care that they need in other parts of the system. And so one solution to deal with that would be looking at a centralized referral system, where the onus would not be on the family physician to be chasing those referrals, but we'd have a centralized way of managing them. And then we have other areas where there definitely is room for improvement, including things like eliminating sick notes, building in the supports within primary care to help us to manage that administrative burden. And some of those will be technological solutions. Okay, next slide. And finally, I'll just touch on the compensation piece. So we have been advocating at the OCFP to our partners at the Ontario Medical Association for the need for fair remuneration for family physicians. And I think we all know that there are clear inflationary pressures, and that ultimately is contributing to increased costs of running a practice. And so really, we know it is an important piece for us to look at and to address in order to make family medicine a feasible profession. Next slide. Okay, so I'm going to shift gears a little bit here. I'm excited to dive into this part because I'd really like to spend a bit of time talking about family physicians as health advocates. Next slide. So I've touched a little bit on the work that we do at the Ontario College of Family Physicians, and I noted in our mission that we take a number of different approaches to supporting our members. What I will say is that I think we've realized over the past many years how important it is for us to be doing advocacy work and really trying to amplify the voices of family physicians. We know that family doctors bring such an important lens to discussions around healthcare. And so we try to leverage that and bring that expertise to the table. And of course, when we're supporting family physicians, we are ultimately supporting them to support their patients. And finally, I'll just say we have seen that by using data, so I touched on the 2.3 million patients who don't have a family physician, and using stories, because I think we have so many in family medicine, it really helps to build a case when we're advocating. Next slide, please. And this is one of those examples of where we were able to pull together data and then weave in stories to help really paint a picture of what's happening in family medicine. So this is our Life Without a Doctor campaign that the Ontario College of Family Physicians ran prior to the provincial election in 2022. And really our goal with this campaign was to raise awareness about the shortage of family physicians in Ontario. And if you look back, or if you think back, this was a time in Ontario where, well, I think everywhere, where we were dealing with sort of that really tough stage of the pandemic. The healthcare system was definitely showing its cracks. And I think at times it felt like people forgot that that also impacted family medicine, that we were also dealing with challenges, both relating to the pandemic, but also pre-existing challenges. And so really by running with this campaign and talking about the number of patients who didn't have a family physician, I think we were really able to catch the attention of the public as well as government and other key players in healthcare, where it became much more common to then hear people talking about the shortage of family physicians. And I think what's really interesting is, you know, when you speak about patients who aren't able to access care from a family doctor, it seems to naturally lead to a conversation about how important a role we play in the healthcare system, which I think is just a really nice way of illustrating why this is such an issue. Okay, next slide, please. Now, I wanted to spend a few minutes on this slide, and I think it's my attempt at convincing anyone out there who would like to think about advocacy to really understand why I think family physicians are so well positioned to do so. We heard about the CanMed's roles and how being a health advocate is an important CanMed role. And I think I'd like to just touch on kind of how some of what we do as family physicians can help with advocacy work. I'll start by saying, you know, we really do bring a depth of knowledge to advocacy work. We see as we are helping our patients to navigate the system and we're trying to access care for them, I think we very quickly see where the cracks are and are able to bring that lens to conversations around healthcare. I would say our trusting relationships and just sort of being trusted players in the healthcare system is quite helpful. And, you know, I thought about, you know, often we are enabling our patients to try to take charge with their health. And I see advocacy in a similar way, where we're sort of helping to point out where there are challenges and really trying to bring that primary care lens to then enable movement in the right direction in the healthcare system. I won't go through the rest of these one by one, but I will just land on, now, I think the passion that we have as family physicians to really help our patients and to make things better, and the compassion that we bring to our work is so beneficial when we're looking at advocacy work. Because really, I think we're trying to make changes in the system because we care, and we don't want to see patients getting stuck in places where we've just really not addressed challenges in the system that can be addressed. And my final point is just, we make such a difference as family doctors in the work that we do, and it's so important for us to be able to bring that the lens that we have in the work that we do to discussions around healthcare transformation. Okay, next slide. So I'll just loop back to this patient story again. So what I didn't tell you earlier was, and I touched on it a little bit, but this patient, by the time we got his CAT scan, I can tell you that it was just really challenging, and it was partly just everything was taking time. It was hard to get him the investigations that he needed. It was hard to really get him in to see a specialist. And so I kind of felt like we were, you know, going at it alone, trying to just run with things and manage it. But a big part of my role was trying to help navigate the healthcare system. And I think in addition to really helping me to appreciate how much the relationship that I had with this patient helped him in that time, I think it just also helped me, as much as it did bring me, I think, some of that moral injury that Mike touched on. I think it also helped me to see how important it is for us as family physicians to draw from the work that we do day to day to help inform changes within the healthcare system. And really, it opened my eyes to how much we bring to advocacy work and how much we're able to sort of flag issues that other people may not see right away, but we're seeing because we are doing this work day in, day out as family doctors. Okay. I will just touch for a moment on my story as a health advocate. And I think that I'll say, you know, I certainly didn't start out as a family physician saying, you know, I want to be the president so I can advocate for family physicians and for my patients. And I think I'd say, if anything, I kind of stumbled into advocacy a little bit. And for me, it started with just really wanting to be involved. And so I did a lot of work within my own community in Cambridge, and got involved with committees, both within my family health team and my hospital, as well as the broader community. And then I think I just realized I really liked bringing my voice to the table. And I felt as though when I was facing challenges in practice, and things that really bothered me and made me feel like I wasn't able to do what I needed to do to help my patients, I really liked having an outlet where I felt like I could actually take those issues and vocalize them and hope that something would happen. I like to say that before I got to the OCFP, I kind of felt like I was a little bit of a thorn in everyone's side, because I would often point out those gaps and cracks and challenges. And I think my goal was just to make things better. And when I got to the Ontario College of Family Physicians and started on the board, it seemed like that information was really helpful, and it helped inform some of the work that we were doing, where, again, I think as a family physician, sometimes maybe I saw things before others may have, and was able to sort of point out issues that we saw day to day in practice that needed to be addressed. So I will just say, I think for us as family physicians, and for me certainly, it's been really nice to be able to pair advocacy work with clinical work. And I think it's just a really nice way to sort of bring some of the challenges that we face as family physicians in practice to the forefront, where you can then essentially affect change. Next slide. And I'm going to actually this is my last slide, and you've heard a little bit about the announcement earlier today. I won't go into details, but I will just say advocacy does work. Advocacy, I think, can feel slower. I think as family physicians and as physicians in general, we're used to seeing an issue and taking action, and seeing that action often have an effect. And I think advocacy requires a different approach, and it often requires more patience, perhaps. But that doesn't mean that it doesn't move us in the right direction. So I'm just really pleased that after months and months and months of lots of advocacy through the OCFP and many other organizations, I'm really happy to see that we have the announcement from today from our Minister of Health for $110 million to support existing and to expand primary care teams across the province. Next slide. And that was everything from me. I will pass it back to Dr. Varma.
Awesome. Hey, Dr. Green, Dr. Kumanan, if I was going back into training, I want to be a family doctor. Like I said, it's, go into medical school, awesome. Get into residency, even better. But be a family doctor, priceless. And in Ontario and in Northern Ontario, it's such a joy. I know that, we've had a lot of information, but I want people to stay online. We're going to take a 5-minute stretch so that people can just get up. It's about health, and get up and stretch and avoid getting a clot in your legs or whatever. Get a glass of water and down it, and we'll be back at 7:05. I would ask you just to stay online, but for the panelists to turn off your mics and your video, and then come back at 7:05. But honestly, thank you, Dr. Green and Dr. Kumanan. I know you're sticking around so that people can ask you some of those wicked questions that they want to, and I'll be first in line. So see you back at 7:05, folks. Take a break. Welcome back, everybody. I'll ask our next speakers to turn on their videos. I really, again, want to really thank the first two speakers we had. It's been a row of presidents, President Verma, President Green, and President Kumanan. And so let's go to the real people who actually are still working and the most inspiring group of people I've ever met. And I really want to turn it over to Julie LaRue, who's also a president, actually. So there you go, yet another president. But she'll get a chance to introduce you to our next panelist. Over to you, Julie.
Thank you. So I'm also very inspired by all of these people, and I'm excited, of course, to introduce them to those attending tonight. So we have three of Northern Ontario's very own, Dr. Dave McClendon, Dr. Adam Moyer, and Dr. Sarah Newberry, who I think will all be sharing some of their own stories during this next talk. So I'll leave the introduction there, and I'll leave it to them.
Hello, everyone, and thank you very much for inviting me to this. This is a very exciting and awesome shindig that the students and Brady has put together. I think this is awesome. My journey to family medicine was very northern based. Dr. Green was mentioning Family Medicine North. I was in the first graduating year of that residency program way back in 1993, before NOSM actually existed. I've practiced for 7 years or so in Sioux Lookout, and I've been in Huntsville for the past 24 years. So I've had a kind of a long and storied past history in family medicine. So the one thing about physicians, and I think family doctors specifically, is we're storytellers. We teach by stories. We learn by stories. We anchor our clinical information in the stories that we have. So I've gone one better, and I actually brought a picture. So I've got a picture and a story. So I'm hoping that this picture shows up on everybody's screen. And I'd like to introduce you to Ethan. Now, before I go any farther, Ethan is not his real name, and his mother has given me permission to share this picture with everybody. Now, everybody, whenever I show this picture, they're always looking at it and they're saying, well, who's who? They're almost identical. So I'll just orient you. I'm the one on the right in the yellow. Ethan's the cute toothless kid on the left. Okay, we're all clear now. All right. So this picture was taken on Halloween. Ethan is 5 years old, and his mom asked him, "What do you want to be for Halloween?" And he said, "Well, you know what? I want to be Dr. Dave." And she said, "You want to be Dr. Dave?" And he said, "Yeah." So they had pictures of me, and so he's got the stethoscope that I gave him for Christmas, and he matched my pants and he matched my shirt, and he actually pulled off the gray wig really well as well. So this was Halloween. Now, Ethan kind of has a fairly, I like to think, healthy obsession with me as a family doctor. He's not my patient. He's a patient of my wife, Nancy, who's also a family doctor in our practice. But I had the honor of delivering his brother, and he thought that that was just kind of the coolest thing ever. And so we kind of got a special relationship. And my office staff actually will occasionally book appointments just for me to go in and say hi to him. Now, whenever I show this picture, and I've showed this to my daughter before, my daughter says, "Dad, that is such a flex." And after I got her to explain what that meant, because she's a 20-something and doesn't speak my language sometimes, I kind of thought about this, and I thought, you know, it is a bit of an ego thing, and it is a flex. But to be really honest with you, this kid kind of revitalizes me when it comes to thinking about family medicine. This is a kid that he kind of sees what we do as family doctors with kind of the innocence that a kid has. And when you really think about it, we do some really, really, really cool things. I've been in practice for a while, and I've just, like Dr. Green, just recently given up doing deliveries. I've figured out I've brought somewhere between 600 and 800 kids into the world. That's pretty cool. I've watched a lot of those kids grow up and had their problems, and that's pretty cool. I've held hands with people as somebody's dying in their family, and that's horrible, but you're there for people. I think, when we're often thinking about family medicine and we're thinking about all the difficulties that you see in the public, in the press, as family doctors, you go back to your practice. These are people that you've known for a long time. They're people that you've done a lot of things for and a lot of things with. You go back to the community that you have. And as a family doctor, you're somebody in that community and you're somebody caring for those people in that community. And you hold a special place for all of those. And I think we sometimes forget that. Um, I know advocacy and all these big issues are very important, but at the end of the day, it's a relationship. It's a relationship that we have with our patients. It's a relationship that we have with our communities. And I think it's a relationship that makes us very human. And I think family medicine is probably the most human thing you will ever do. To be able to see people progress through life, to get to see people, some of your patients, and we all have them, they're difficult patients, but you can see them get through some of those problems. And we have the time to do that. And longitudinal care is something that is a gift as a family doctor. So I think my message as a family doctor that's been around for a while is when everything seems like it's falling down, and I don't think that this is going to last forever. I think there's amazing people, many on this panel, that are going to help fix and are going to set some of the protocols in place that are going to make things better. But when you're feeling like things are really falling apart, go back to your practice, go back to the people that you're caring for. For the students online, I am always encouraging them to be family practice. I think it is probably one of the most joyful things that you can do as a practitioner. And I can say nothing but good things about it. I think somebody like Ethan, who's bound and determined to be a physician, is probably going to be a family doctor, I'm hoping. But again, I would encourage you to kind of think about those patients and those communities and those relationships. And I will actually turn it over to Adam now, who I've known for most of his career. And I can think of nobody better to be talking about the joys of family medicine, because Adam's a pretty joyful guy. Adam?
Thanks so much. Like all professional speakers, I was texting other speakers on the panel saying McClendon is killing it right now. So I'm really glad I actually changed my talk, because Dave and I had the same talk. This is a joy and an honor to be here today. I have a couple of slides. If we could change to the next one, please. I always find that the fall is a hard time for me. It is, it's getting colder. We're not able to do outdoor activities. In Dryden here, it gets dark at about 4:15 in the afternoon. And it's a month that I usually grind through. But if any of you are familiar with NOSM sends out second-year learners in November. And I got two gifts this November, a couple of learners that completely blew me away. Their positivity, their courage, their bravery, their resilience. And it brought me to the topic of my talk, is that our resilience, our joy, can be found through our learners and cultivating those learner relationships. So this is to them. I was lucky enough to run into one of these learners downtown, and my family, of course, always becomes a big part of these learners' lives. So when the phone rings, my kids will say, is that Dr. John? Is that Dr. Sarah? Is that Nusha? They want to know who I'm talking to because they've become a part of these learners' lives as well. So I think, we reflect on the things if we open our ears as faculty to the things that we can learn from our learners. So for example, I didn't know this at the time, but the two learners that were sent to me from NOSM were both Queens. And they like to work together continuously, and they would address each other by Queen this, Queen that. And thankfully, by the end of the month, I had been elevated to King status. So we would do a learner presentation. The first learner would present. Before I could say anything, the second learner would comment, "Oh my goodness, Queen, you killed that." And then I would say, well, usually the preceptor gives the feedback, but yes, that was a very good presentation. And inevitably, they're very early in their learning stage and they had things to learn. But whatever the feedback they had, it was always taken positively and with a lot of resilience. So it was quite remarkable. And I'm very grateful for those learners coming into my life this past November. We'll do the next slide here. A big part of learning for me is doing everything that I do. So experiencing the full gamut. So that includes house calls, visits to long-term care facilities. Dr. McClendon talked about this, but our patients teach us so much. And this was a very elderly patient who took me on as a doctor. And she was about 95 at the time. And I could do nothing good for her medically. But she appreciated the house calls. I would go and do a house call. Her blood pressure would be 205 over 130. And I would say, I'm doing a horrible job as your doctor. She says, just imagine how high it would be if you weren't here. So she always taught me to take a strengths-based approach to everything we do. And learners in these instances taught me boundaries because I'd bring learners to these visits every single time. And she would have black coffee and chicken salad sandwiches and Twinkies every time. And I don't like any of those things. But I would drink all the black coffee. I would eat the, 2 halves of a chicken salad sandwich, and I would eat the Twinkie to finish off it. I told her one day I had a learner coming, so she brought out 4 chicken salad sandwiches, 2 coffees, and 2 Twinkies. The learner who was pregnant at the time turned to me and whispered and said, "I'm not eating these sandwiches." So I don't have the same ability to establish boundaries as that learner did. So on that day, I ate my first chicken salad sandwich, and then I grabbed the learner's salad sandwich. I said, "I'm so hungry, I'm eating hers too." So I subsequently ate all the chicken salad sandwiches and Twinkies. And from every house call then on forth, I had to eat 4 chicken salad sandwiches because she thought I was that famished at each visit there. So learners teach me that you can say no. I still haven't figured that one out on house calls, but it was a gift from both the learner and the patient. We'll do the next slide, please. I have young children, and they are obsessed with these 2 people, Taylor and Travis. And I knew really not very much about this. I didn't know that I should be worrying about this relationship status on a daily basis. But those 2 learners that have come in November and before that have taught me everything I need to know about Taylor and now Travis. And now I am worried on a daily basis. Will these 2 get engaged? Will they stay married? Can she go to the Super Bowl? I didn't know that my album is Reputation. So thank you to those learners. And now I am so relatable to my children. And it's because of learners and me listening to what they have to say that I contribute to that there. We'll go to the next slide, please. Medical learners, especially earlier in their career, have a sense of awe and wonder. And it can be about the smallest things. So I was working with one particular learner on the ward, and all of a sudden, I was teaching an ultrasound topic. I was doing my best job. I was killing it on this day. And I could not get this medical learner's attention as she stared off down the ward. And finally, I had to stop. I said, I'm talking to you about lung ultrasound. This is really valuable stuff. And the learner whispered to me, "Is that a cat?" And I looked, and I kind of peered down the hall. I said, "No, that's not a cat. That's a cat robot. They gave it to the very demented patient because they love animals." So instead of getting back on track, the learner said, "Do you think I could hold the cat?" I said, "No, I think that'd be very distressing to this patient." But this learner had a complete sense of awe and joy with seeing this robotic cat. And they apply that to everything in medicine, to giving their first flu shot, to doing their first cast, all those things. And if all of us faculty had more of that joy and awe in our daily lives with the very important jobs that we have, as Dr. McClendon mentioned, we'd probably all be a lot more joyful and happier at work there. That learner now owns a robotic cat named Pierogi. That was my end of rotation gift to them there. Next slide, please. Learners can also be mentors, and this is kind of an unconventional topic, but several of the learners who have worked for me are now my mentors. They're mentors in emergency medicine. They're mentors in psychiatry. And for me, I worked through the pandemic as an immunosuppressed person, and the guy intubating there is now a London ICU physician. And he would call me and give me advice about taking personal precautions, what he was seeing with COVID in the ICU, and supporting me through that process. So he's one of my mentors. The guy on the left is a well-respected ER doctor in Dryden. Another one of my mentors, I get into a tough case and I ask them for help. So that relationship can be reciprocal, and I think that's a really important concept for us as faculty there. Next slide, please. This is, again, another learner who came through and is now a mentor in the capacity of mental health. And supporting others and supporting each other. So this relationship and this ability for learners to learn from us, but very, very quickly that relationship changes and we end up learning from them. And I'm tremendously grateful for that. So I think that's the last slide that I have up here. My presentation today is in the context of someone who's grieving. We lost one of our dear, dear friends in Dryden and an awesome staff person, Chuck Schmidt. And Chuck Schmidt, whenever he encountered you, his job was to leave you with a little bit more joy than when you started that encounter. And he did that on a daily basis. And if I can do that for my learners on a daily basis, I've met my goal. And I'll tell you this, and hopefully a lot of them are listening because I've been texting them all day to attend this session. It's mandatory. They're not going to graduate unless they do. I have your assurance there, Dr. Verma. For sure. So, you guys bring joy into my life every time we are encountered. So I'm so grateful. Thank you so much. And I'm going to pass it on to another very joyful person, Dr. Sarah Newberry.
Thanks so much, Adam. That was terrific. My name is Sarah Newberry. Like Adam and Dave, I'm a rural generalist physician. I live and work in the community of Marathon in the traditional and unceded territory of the Ojibwe people of Bigtugong First Nation here on the North Shore of Lake Superior, and I have been here for 27 years. I want to begin by saying thank you for the opportunity to be here. I think Adam has really beautifully articulated the way in which relationships inform a sense of joy for us. And to be here with Mike and Mahale, Adam and Dave, who are colleagues that I've known for a long time and colleagues with whom I have a relationship that I truly value, that is a source of joy for me. So thank you again to the Student Council for the invitation to be here and participating in this. I want to just sort of pull back a little bit and think with a different lens about joy. We have talked, and I think Mahale has alluded to, and Dave has spoken to, the conversation that's a pretty live conversation right now about burnout in family medicine and burnout in medicine generally. But I think if we're going to move away from burnout, we have to know what it is that we're moving toward. And we need to understand that the opposite of burnout is not resilience. Resilience is just what helps you to keep going when you are burned out. It helps you keep putting one foot in front of the other. the opposite of burnout is actually joy in our work. And so if we're going to move towards joy in our work, we need to understand where it comes from. And I think Dave and Adam have really beautifully articulated some of the sources of joy, and what the literature shows us and what we know as family physicians is that joy in our work really comes from three sources. It comes from relationships, good relationships with our patients and with our communities. It comes from good relationships with our colleagues and with our teammates. And it comes from a sense of purpose and mastery in our work. It comes from being skilled clinicians who can offer a service that is impactful for our patients. And all of those things, forming good relationships, sustaining good relationships with our colleagues, developing our sense of mastery, developing our clinical excellence, all of those things take time. Mahale, I think, articulated really well the important focus on decreasing administrative burden in family practice. And I think we need to understand that not necessarily for simply freeing up time to do other things, although that might be part of it. But when we decrease the administrative burden, we free up time in our workday to build better relationships with our patients, to have more time to build relationships with our colleagues, and to focus on our clinical skills that truly gives us that sense of mastery and purpose. And because joy comes from relationships and it comes from the application, the good application of our skills, we can have joy in our work even when things are very difficult, even when things are really painful. Adam's mentioned that relationship that he had with Chuck, which he is grieving, but which has been a source of joy for him. Mahale illustrated a story of a patient to whom she had to break bad news. And I want to share a story with you as well that's very similar about a patient of mine who I had known in my practice for over 20 years, who was not just a patient, but a friend and had been a colleague in our hospital setting when I first launched as a very green new family medicine graduate. And she came in one day at about the age of 70, long postmenopausal, with symptoms of a really unusual discharge. She didn't have bleeding, but she had a discharge that just alerted my spidey sense. And so we did an exam and got an ultrasound. The ultrasound was normal, but I chose to do an endometrial biopsy well within our skill set. And we did that in our hospital setting. Those results came back to me and they showed a serous adenocarcinoma of the endometrium. I wept reading those results. I booked an appointment for her for the next day. I wept that night. I slept horribly. I wept during her appointment with her. She wept. We had a conversation about what that diagnosis might mean for her, but we also had a conversation about the way in which we would move through that together. Whatever came as that chapter evolved and whatever came with the next chapter of her life. And like the story that Mahale illustrated, when she left the office, still crying, she gave me a huge hug and said, "Thank you. Thank you for doing this. I know that that was hard for you too. Thank you for being here and thank you for walking with me through this journey." And even though that was hard and sleepless and sad, and I had huge anticipatory grief about how her story would evolve, there was still a source of joy for me because of the relationship and because I felt good about my clinical skills and my diagnostic ability and my ability to follow her through what came next. And I want to take a minute and just come back to that notion of continuity of relationship in comprehensive practice. Mike spoke to it at the beginning of his talk or partway through his talk. Mahale had a slide that illustrated that continuity of relationship in comprehensive practice does all kinds of things, decreases emergency room visits, decreases hospitalizations, improves health outcomes, and in fact, decreases mortality. We know from the literature that the stronger the attachment to the family physician, the greater the degree of continuity, the better the health outcome over time. Continuity saves lives. Mike alluded to that as the secret sauce. I think of it a little bit differently. I think of continuity of care in relationship to us as good family physicians as being the medicine. Family physicians, good family physicians, are good medicine. There are very few medications that decrease mortality and improve health outcomes as much as continuity with a skilled family physician. And for me, the knowledge of that impact, the knowledge of the meaning of our work, even when, to Adam's good point, there are patients that we see who are 95 and we feel like, I don't really know that the medication I'm prescribing is making a difference. It's not about the medication. It's about the relationships that we have. That's the medicine. And I think for me, just simply a huge source of joy and sense of purpose in this work. So I will close there and I will hand it over, I think, to Div Patel. Over to you.
Thank you so much for those amazing panelists for giving their perspectives. Up next, we're joined by Dr. Rebecca Bourdon, Dr. Shondell Mansour, and Dr. Emily Gillisey, each sharing their unique perspectives on why they chose to pursue a residency in family medicine.
Hi, everyone. Thanks for having us here. We'll go to the next slide. Okay, perfect. So my name is Rebecca. I was born in Sudbury, and I count myself as one of the lucky ones to have graduated from NOSM University. Just to align my introduction with the essence of this talk, I've just listed here the electives I undertook during my 4th year at NOSM, specifically chosen with the intent of pursuing a career in family medicine. They covered the human lifespan, as you can see, from pediatrics to palliative care. They extended across diverse healthcare settings. I worked in the emergency department, hospital wards, outpatient clinics, as well as in various medical domains, ranging from psychiatry to reproductive health care. And my medical training also provided me with valuable opportunities to engage in leadership initiatives and advocacy efforts. And all of these experiences helped pave my path towards family medicine, and are inherent to the role of family doctor. I'm currently in 1st year of residency in Toronto, and I continue to look forward to embracing all of the growth and the challenges that come with this new chapter in my medical journey. So thanks for having me. I'll go to the next slide.
Hey everyone, my name's Shandy. Thanks again for having me as well. I am a 1st year NOSM family medicine resident based out of Sudbury. I was, like Rebecca, born and raised in Sudbury as well. And I did my Bachelor of Science in Biomedical Biology in Sudbury as well at Laurentian, and was lucky enough to get into NOSM and did my undergraduate medical education, you guessed it, again, in Sudbury, on the Sudbury campus. So you could definitely say I love Sudbury, and I do. In terms of my 4th year electives, I did a variety of things. I went back to Timiskaming Shores, where I did my 3rd year and did some rural family medicine electives there, as well as some pediatrics, obstetrics and gynecology, ENT, radiology, and hospitalist, things that I thought would help me out during my family medicine residency and career. In terms of interests, this is kind of difficult because I have a lot of interests, which I think led me to family medicine, which we'll talk more about later. But specifically, I'm interested in reproductive health, mental health, and hospital medicine as well.
Hi everyone, thanks so much for having me as well. I'm Emily. I am born and raised in Kapuskasing. I am also a 1st year resident at NOSM, and I am doing the rural stream, and I'm based out of Kapuskasing. So I'm back home, and I'm really lucky, and I feel grateful to be able to practice in my hometown. I did my bachelor's degree in nursing at Laurentian University, and then my medical undergraduate also in Sudbury at NOSM. Some of my interests include low-risk obstetrics, reproductive health, addiction medicine, emergency medicine, hospitalist, and just general family medicine. So in fourth year, I did come back home. I did some rural emerge, some hospitalist medicine, as well as some obstetrics and gynecology in North Bay. And I had the chance to do a rotation in Hearst in one of the nearby communities here. We can switch the slide and I can get us going if that's all right. So we were asked to talk a little bit about why we chose family medicine. For me, I've always known I wanted to do a career in healthcare, specifically interested in family med when I was doing my summer studentship at the family health team back home during the summer of my bachelor's degree. I just realized how big the need for family doctors was and how negatively it impacted a patient's life to not have that continuative care and preventative care that family doctors offer. I worked in the emergency setting as well in fourth year, and I've encountered hundreds of patients requiring a family doctor, and I just thought that I could maybe help out and fill some of those gaps in my hometown. I find family medicine so fulfilling and rewarding, having the chance to really build the relationships with your patients and get to see them from birth to end of life, and really following them through their healthcare journey is something I really appreciate and love about family medicine. I like that you can tailor your practice to your interest as well as the needs of your community. For example, we have a big need for low-risk obstetrics, and I happen to have a big place in my heart for that. So this morning I was lucky enough, I delivered a baby, and then I went to family clinic, and then this evening I'm doing an emerge shift. So as you can tell, it's a little bit of everything, and that's what I love about it. And I'm hoping to have a similar practice later in my career. Yeah.
Yeah, absolutely. I totally agree. Variety, as I have listed there, is one of the things that made me want to go to family medicine as well. Just being able to see patients from all different stages of life and different ages and different clinical presentations. And for me, I found I didn't necessarily know I wanted to go into family medicine right away, but through different rotations, I found that I liked a lot of it. So I liked pediatrics, I liked women's health, I liked psychiatry, and it made making family medicine a easy decision because I get to incorporate all those things, into family practice and sometimes into just one day as well. And additionally to that, we all have continuity of care listed there, which many panelists have touched on already, but just something that's super important for not only the patient, but also ourselves. Like Dr. Newberry said, just having that joy. And just to reiterate, like she said, continuity saves lives. And I really liked how she said that as well. Additionally, in addition to that, flexibility, kind of like you were saying, as well, being able to choose your practice setting, being able to incorporate many different things into your practice as well is something I really love. I love community healthcare, and I also love hospitalist. And, if I end up working rural one day, maybe I'll deliver babies as well.
And just to share my thoughts on why family medicine appeals to me, if we could just also go back to the previous slide. Perfect, thank you. So number one, advocacy is not just a side gig, it's integral to the family physician's responsibilities and aligns with my commitment to addressing systemic health issues. So it's both necessary as well as very rewarding. Number two, the breadth of knowledge required in family medicine, spanning various medical domains, is really inspiring. And then the ability to become a lifelong learner is very fulfilling in itself. And then just to echo my colleagues, the capacity to provide continuous care sets family medicine apart from every other medical specialty. Even though I'm only 6 months into residency right now, I've come to really appreciate the privileged vantage point that is afforded to family doctors from observing patients over multiple healthcare visits, and the trust that is built over time, which helps both the ability to diagnose and to treat. And these aspects all collectively make family medicine the ideal choice for my medical career. Go to the next slide. Thanks.
We were also asked to talk about what we envision our future career to be like. I just so happened to have a really exciting day today, and it just made me think about how lucky and fortunate I'd be if I could do that every single day throughout my life. Maybe not the night shifts every day, but the broad scope of practice, being able to do obstetrics and family clinic, and then emergency medicine, hospitalists, and all of the above. So I do envision myself having a comprehensive family medicine clinic back home in CAP, and practicing all sorts of different fields of family med, as well as being a teacher and a mentor for future medical students. I was lucky enough to have really wonderful mentors throughout my nursing and my medical training. So I'm hoping to sort of give back in a way and be able to be that mentor for someone in the future, and to persuade them to come back and work in our great community of CAP. I'll pass it to you, Shani.
Absolutely. And for me, I think I'll probably start by locuming, in Sudbury and surrounding communities. Maybe I'll come visit you in Kapuskasing. And I just am hoping to go back to some of the communities I've already built some ties in, and again, have had amazing mentors, and going back to communities like Timiskaming Shores and Manitoulin Island is something I really want to do, and also just get experience in different practice styles and see exactly what I like. Overall, I think I would want a combination of, community medicine as well as hospital medicine. And again, if I work more rurally, opening that up to have a more broad scope of practice as well. In addition to that, I do really want to have a role advocating for Northern healthcare and healthcare professionals. Part of that being, part of committees and supporting policies to help support primary healthcare and addressing family physician shortages. I think a big part of that for me would be education and training, and having academic involvement at NOSM, and hopefully being a mentor, like how I have had mentors in the past, and going forward in that direction.
Yeah, so to talk about our future, it's actually crazy to think about so close. It's only a year and a half away, which is really short in the grand scheme of our educational journey to get here. So it's very exciting. But looking ahead, my future as a family doctor involves embodying basically all the characteristics that drew me to the field in the first place. So including in this is practicing comprehensive medicine, and by doing so, hopefully bridging gaps in our healthcare system. I also aspire to be an academic mentor, fostering the growth of future healthcare professionals and becoming the role model that I looked up to during my training. And I also see my future career as having a healthy work-life balance by committing to compassionate patient care and personal well-being. As a mother of two, I need to prioritize my role in my family just as much as my role in my career, to ensure continued fulfillment in my career and to prevent burnout. We'll go to the next slide now. Perfect.
All right, so for the last point, we were also asked what we thought the future of family medicine would entail. When I was thinking about this question, I know that we've been knowing more of and getting to know more about virtual medicine, especially in rural communities we had already a role with the virtual critical care, but as we went through the COVID pandemic, virtual appointments became almost a regular thing. And I think that in the future, there's definitely some pros and cons, but I think we will definitely be seeing more of virtual visits, and especially in rural northern communities, in patients that don't necessarily have access to travel for healthcare. I think it would be of great benefit for that population. So I'm excited to see what's to come next. The last cool technology I've seen was a stethoscope that you can actually put on the patient, and the virtual critical care doc can actually listen to the patient's heart and the patient's lungs. So I'm just really excited to see what the future holds in terms of virtual care. I also expect to see a little bit more of the plus one programs being integrated, such as the plus one in Emerge, plus one in obstetrics, addiction medicine, surgical skills, as well as needing more family physicians as we move forward. I've noticed as doctors retire, they tend to have had bigger family practices. So now that they've retired, the newer docs tend to want a more balanced lifestyle and don't want as many patients as I guess the older docs used to. So I'm sure we'll need even more family doctors in the future too. So those are kind of my predictions.
Yeah, and with needing more healthcare professionals, as you were saying, hopefully how I envision the future is retention of those healthcare professionals as well, in Ontario as well as Northern Ontario, and part of that being like increasing the amount of learners within Northern Ontario, and part of that being like increasing the amount of medical students training at NOSM as well. So I hope to see that. I also see a focus on preventative care and health promotion, you know, in my own practice as well, hoping to reduce and prevent chronic diseases and having a big focus on disease screening as well. And as well as increase access to healthcare, as Emilia, you were touching on, having that virtual care and OTN and having those technology advances, I think will definitely help places that don't have as much access to healthcare have more access in terms of rural and remote locations as well. And yeah, Rebecca, you can go ahead.
Thanks. Yeah, so contemplating the future of family medicine, I think it's both really exciting, but also a little bit daunting. Like everyone said, there's clear physician shortages, and I think there will be an increased emphasis on, number one, like multidisciplinary team-based care, which may involve, you know, recruiting other healthcare providers to fill in the distribution gap of family doctors like NPs, and also more collaborative interdisciplinary teams in outpatient clinics, including like social workers, pharmacists, nurses, shared care models, etc. I think this would help with the challenge of coordinating patient care that we see today. And as we continue to see more advancements in technology, I think this too will improve accessibility and efficiency in the healthcare delivery, obviously when strategically implemented. So with the goal of integrating electronic health records rather than creating multiple siloed record systems. And I also hope to see the future of family medicine as focusing on preventative care and population health. And I think that will necessitate policy and funding changes to, you know, incentivize more family doctors to focus on preventing chronic diseases and addressing the social determinants of health. Thanks. Oh, we can move to the next slide. Sorry.
Thank you again for having us.
Yes, thank you so much.
Yeah, thank you.
Wow, so this is great, Emily and Shandi and Rebecca. The future is bright. You know what? It was great that you were able to take time out of your busy schedule. And honestly, it's just really, really exciting that that we have you as the brain trust of family medicine. I'm looking forward to it. I am, moving to retirement, and as I relocate, one of the biggest things that affects me is that I'm actually more worried about finding a new family doctor and relocating, because I have a lot of, I'm old and decrepit, but I will have a few needs for ongoing care, especially as you age. And I think that the fact is we are in great shape. We just need to do more. And expansion of the medical school, as you said, the introduction of virtual medicine, and so many exciting technological advances, they're going to only help family medicine. They're only going to help us as we go forward. What we'd like to do is spend a bit of time, having some questions. I know we were going to take a break, but I feel like if it's okay with the panelists to forge on through and get people out early so they can have their late dinner or relax a little bit before read if they have to study, which I think many of the students and residents do. So, I mean, first thing I'm going to say is actually a question for Dr. Kumanan and Dr. Green before we go to the questions from YouTube, because we have a few. And feel free to put your questions as have been indicated in YouTube or in the WebEx, and we'll be able to ask them. And it does go to the use of artificial intelligence and technology. Mike and Michael, where do you see us being able to integrate this? Because I have practices in the north that still use fax machines, and I'm a little worried that we haven't had the investment in the use of technology. And Mike, if you want to go first, and then Michael, that would be great. And of course, if anybody else wants to comment, let me know.
Sure. Happy to talk. Actually, it was great. The Mehalai will know the Ontario College of Family Physicians just had their Family Medicine Summit on the weekend, and Dr. Goldfarb from U of T was talking about AI and family medicine there. And so I think there's two things. One, I think it has great potential to help us with some of the things that really are annoying for us to do, and we could use the help. And I think about simple things like, can AI do a better job starting to write a letter or a form for us? Like, just to start, pull information out of a chart and put it somewhere. Can it be a scribe? These AI scribes are out there. I'm on a couple of meetings where people have those AI otters, and they transcribe the things for her. That might be a nice thing to help our notes for the day. And they're really about helping us make decisions. So I can see it be them, AI being helpful in some decision support. There's always risks because, AI only knows what it knows. So you have to worry about bias. You have to worry about, is it just going to, enhance good outcomes for the people who already have them and make decisions and leave out information for you that goes the other way. But I think there's good promise. It won't replace us. What it won't replace is it won't replace that relationship that we have with our patients and the need that people have for somebody trusted to sit by them as they go forward. So even for diagnostics, if AI can help guide someone on a path of self-care, self-diagnosis, I think I might have this, or help us say this is what might you be, doesn't give them all the answers as to what they should do. So I'm excited about it. You're right. Maybe you can skip a whole generation of technology. So what I think about for the North is that Africa is a really interesting place where they bypass certain eras of technology altogether because things were so far behind. So if you look at mobile banking as an example, when we were first getting our phone banking apps here in the Western world, it was already taking off even well before then in countries like Africa because there wasn't a big network of bank branches and there wasn't a big network of infrastructure that was built on the old way of doing things. So I would think maybe an opportunity for the North in family medicine would be, how can you leapfrog to the best application of technology that's there and take advantage of what's there.
Great. Dr. Kumanan, did you want to say anything about that?
Yeah, I'll build on what Mike said, and I certainly agree with everything that he's touched on. I think when we look at the administrative burden that I talked about, I think we know that we're probably not maximizing technology, and that there's a lot of untapped potential that we could use. I have not yet got there, but it's high on my list. I have many colleagues who've started to use AI scribes, and what I'm hearing from colleagues just anecdotally is it's giving them at least an hour of their day back where they're not sitting down and charting at the end of the day. So I think if we want to really seriously look at how we can help to chip away at the things that pull us away from the work that really does bring us joy, that patient care and the relationship piece, I think it's really important for us to look at how we can tap into some of the technological solutions. And I think, Mike touched on this. There's the science of medicine, and that's where I think AI can be helpful. But we're never gonna not need the art. And I think the relationship piece in family medicine, we know is so important. I think we've all touched on that. And AI certainly is not going to be able to replace us as human beings building those relationships with our patients.
Kim, do we have a question from YouTube?
We do. Thanks, Dr. Verma. The question is there a place or any consideration for international medical graduates to train through CARMS or to work in Northern Ontario through the PRA program?
Maybe we can turn to Mike first and to Dr. Kumanon as well, but I think, maybe others have a comment as well. Mike, what are your thoughts about IMGs?
I'd say it's interesting. I was actually just at a meeting the other day when I was looking at this. People may not realize already that last year, 41% of our new certificates for the College of Family Physicians are people who did their medical training overseas. 41% already today. And that's a combination of people who trained overseas and had the opportunity to come here through a direct recognition pathway of a credential, people who did a Canadian residency and a designated IMG stream, people who did a practice readiness assessment and worked and did a practice entry eligible route to write our exam to become a certified family medicine specialist in Canada. All of those routes. And they're there. They're not enough. I think there's some opportunities for filling in some gaps. Personally, I think there's a gap between practice readiness assessments and full residencies where there's maybe some opportunities. And I know that actually those practice readiness assessments in Ontario have a particular focus on supporting physicians who want to come and work in rural Ontario.
Thanks, Dr. Kumanon.
Yeah, I'll maybe respond with a slightly different angle. I agree with what Mike said, and I would say I think bringing more people into the system without also addressing the system issues is not going to solve the system issues. So I'd say, we need more human beings probably, but we also need to look at ways that we can increase capacity. And I think both team-based care and then really looking at chipping away at that administrative burden will help us to just actually be able to do more of the direct patient care that we want to be doing.
Dr. Newberry is the Associate Dean of Physician Workforce Strategy at Nauseam University, as well as being practicing family doctor. Dr. Newberry, what are your thoughts on integrating international medical graduates?
Yeah, I think this is a really important question. And I think we have an opportunity to really look at whether there could be a laddered approach to entry into practice. So we've talked about residency and CARMS match. We've talked a little bit about Practice Ready Ontario and how we might support internationally trained graduates through that practice readiness assessment into a supervised practice for a couple of years until they achieve full licensure. And that has launched in Ontario for the first time this year. But I also think there may be an opportunity to create some new roles, maybe medical office assistants that begin to ladder people through the system, get them used to the system in Canada, get them into situations in healthcare where they're using their skills and contributing. And I think those skilled clinicians who have trained abroad and who are not working at all in healthcare right now is a real lost opportunity. Maybe at this point, we need to be creating ways that they can be those teammates that Mahale has described so that we're moving the needle in the ways that we can to support patients to access the care that they need. And I think that that's a whole other system stream that is open to be explored.
Kim, what other questions do we have? Maybe we have time for a couple more.
One of the questions we have is, if a medical student is undecided between a specialty and family medicine, can one of the residents tell us how you decided on becoming a family doctor? What did you consider?
I mean, Emily or Shandy or Rebecca, whichever one of you wants to field that question, or any of them, all of them, all of you.
Yeah, I can start. For myself, even before I got into med school, I always wanted to be a family doctor. So I don't know how much I could provide on the perspective of like choosing between specialties. But I would say that, you know, I know there's talk with it being potentially 3 years down the road, but it's one of the shortest residencies. So you could get right into practice shortly after graduating med school. And then another big thing is, for myself, having a family, I was able to, have kids early on. Whereas like in other residencies, I don't know how well it's accommodated for starting a family. Maybe it's a bit more difficult, especially because it's like a longer residency. So it's about like prolonging already a long residency. So I think that was like two really big things for myself that was so intriguing about family medicine, was that I was able to have my own family during this as well.
Shandy, what are your thoughts?
Yeah, absolutely. That's definitely a good aspect of it as well. For me, I I was very undecided for a long time. And I just kind of had to see, for me, I was debating between obstetrics and gynecology versus family medicine, which are very different, but I really liked having different aspects and not just having, one type of patient. And it was reassuring to me that with family medicine, I could still practice obstetrics in a way, and I could still incorporate women's health into my practice, which was important for me. So that's something to look at, like depending what your interests are. There's always the opportunity to incorporate those specific interests into family practice. And so that was helpful for me when deciding.
Is Emily still with us? Do we know? I can't see her name on the list anymore.
I don't believe she
She
is.
started her emerge shift.
Yeah, she's on call.
Yeah. I mean, for me, I went into it late after practicing law for a long time, and it really was that, it was the shortest route to licensure, but it was the fact that you could do everything. Like in the flexibility, I had a very different career. And look at Dave and Adam and Sarah and Mike and Mechalai. We've all had different careers. So you can do global health, you can do, surgery, you can do anesthesiology. Dave, did you originally plan just family medicine, or did you have, I know you wanted to be a rock and roll singer, but other than that, did you have any other aspirations?
No, I was always a family doc. I grew up in a community of 640 people. So that kind of community stuff really spoke to me. Although I remember in my first year of residency, one of the surgeons says, "You have good hands, you could be a surgeon." I said, "Well," and I do lots of surgery and stuff. So family medicine, honestly, is it's the way to go. And if the student wants to talk to me directly, I can convince them that there's no other specialty.
Other thoughts from anyone else? Adam or Sarah, Mike or Bengalai?
I think for me, I love the ability to kind of choose your own adventure, and that can change over time, right? I think we all kind of take different paths to where we end up, but I also just find I'm not someone who can sit still for long, and if I think the repetition of a specialty I would find quite tough. I love being able to go from seeing like a 2-day-old to then going to the next room and I'm seeing a 102-year-old. Like it's just the breadth and the range of what we do day to day just keeps us on our toes in such a positive way. I can't imagine not doing that.
Go ahead, Sarah.
Yeah, I was going to say, I agree completely. And one of the things that I think about as we think about the future of medicine and the future of our culture and our society, is that it feels like it's becoming increasingly complex. And we haven't really talked much about complexity, but I feel like family physicians are really experts in three things: relationships, complexity, and uncertainty. And our future is complex and it's uncertain. And complexity uh, really demands generalism. We know that the answer to increasing complexity is not increasing specialization, it's increasing generalism, which is highly adaptable. And so when I think into the future, I think the base of generalist skills, highly adaptable generalist skills that family physicians bring, will be well supported in the future and is actually the skill set that we need. I also think that as society becomes a bit disconnected, the relationships that family physicians bring to people and to communities will increasingly be a gift and something of huge value to people. And I think about that a lot as I think about the future of family medicine and what our society needs. If I were choosing again, hands down, and probably with even greater vigor, I would choose family medicine.
Me too. I mean, Dave and I actually, True Confessions, were in the same MD class at McMaster. And so we were very all inspired to go into family medicine at McMaster. And True Confessions, Mike and I practiced together at family medicine at Queen's. And I think the thing, my message, Mike, I think it's true. We had a lot of fun. I mean, it was, and we worked all
I
the
would
time.
maybe
And
give
we learned
one
a
other.
lot.
I agree 100% with what people have said about how great family medicine is, if that what you want. But I've spoken to a lot of resident candidates over the years, being in an academic practice, and I don't know how many CARM socials I went to over the years here. But it's like, I think for the people who are uncertain, it's that what's going to bring you joy? Like, what's comfortable for you? Are you the curious generalist who likes to try a lot of things, and are having trouble deciding because you've got, so many things that you're interested in, and you want to go there? If that's you, you're probably best suited for family medicine. If you're not comfortable with uncertainty, the people who are we need specialists too. Like, our specialist colleagues are super important to us. I've got friends who are specialists, and uncertainty terrifies them. So if uncertainty terrifies you, and you like the certainty and a career of certainty where you're like, this is what I'm going to do for 30 or 40 years without changing it up that much, then you're probably a great specialist. If you want to maintain more of that open flexibility, if you're someone who likes to try new things all the times, and you can't decide for that reason, then family medicine is probably a great choice. And follow your heart.
I certainly wanted to travel. I did a lot of international work and, did a lot of global health. And I also, as I said, practiced everything from birth to death. And in fact, the end of my practice, as you know, Mike, in Kingston, was all around care of the elderly. And palliative care became a very enriching part of my life. And, the truth is, it is uh, also so incredibly flexible, right? So I would never have been able to aspire to this job, nor you, Mike, too. I think the College of Family Physicians, because you can't mold doing, and as you said, the same thing. No disrespect intended, but I don't really want to be a colorectal surgeon. I was originally as a lawyer and a physician trying to get people are trying to move me into forensic pathology. Oh, there's a cat behind you, Adam. There's a cat. Nusha, if you're still here, there's a cat. And he's wearing a neck collar. There's something very interesting. Anyway, see, my curiosity and my ADHD has kicked in, but I love family medicine. I could never have been a forensic pathologist. I think that would have done me in too. But I know people are inspired to do that kind of stuff, and that's great. For me, it was wonderful. So anyway, any last comments? Adam, we didn't get a chance to hear from you.
Well, I think, I think about the other day, I spent some time in Sioux Lookout learning from one of my former learners, Dr. Bell. And I thought about their work schedule. They have a hospice program. They have an OB call service. They have a rapid access addictions clinic. They have surgery. They have ER. Almost all those jobs you can do with a family medicine degree. Not the surgery, but almost everything else. So, I mean, I just think it speaks to, if you have a lot of interest, you think you might want a career transition at any point, it's a great job.
So I also love being a detective. I think that when somebody refers something to a specialist, it's usually like, we've, as you've said, and you've discovered, we've done the CT scan and these are the results, and now we're handing it over to you. Whereas as a family doctor, it's like, I have this pain, I'm not sure what it is. And if you like being a detective like I do, and if you like watching all the BritBox show like I do, then you're going to love being a family doctor. And that said, you also have opportunities to do many things here at NOSM University. We're incredibly proud of the expansion, the growth, the curricular innovation, our graduates, and the trail that we're blazing as we go forward. We wanted to spend this time on the joy. We know there are challenges. We know we need family doctors. We know that there are all kinds of issues with models of remuneration and, issues with the way that the government is supporting it. But there are good things. Today we got an announcement that there will be about $100 million invested in primary care in Ontario, and some of it will be in Northern Ontario. NOSM University is thriving and we're growing, and we'll be, making more family doctors over time. Family medicine as a career choice here in Northern Ontario, uh, cleaner air, you'll probably live longer, and you'll get to ski a lot more than you would in downtown Toronto. So I hope that you'll have the chance to reach out to any of us. I've been tweeting a lot, so you've got the handles for most of the speakers here tonight, so you can DM them. I'm sure they wouldn't mind. And I think, Dave, you'll note, I don't think you're on X much, but I did ask the question with your photograph, which one is Dr. Dave McClendon? Because I'm not sure if I could tell. But I loved all the stories. It was great hearing from everybody. And it was wonderful having Dr. Michael Green, president of the College of Family Physicians of Canada, a great friend, a northerner at heart, Dr. Michalai Kumnan, who has now become a friend of NOSM University and is now knowing us, and we hope she'll come up north to see us. And of course, our wonderful 3 faculty members, Adam Moyer, Sarah Newberry, Dave McClendon, our 3 fantastic residents, Chandel and Rebecca and Emily, and the great NOSM University Student Council. Julie, Dave, and Kaylee, you did such a good job. I really want to shout out to Chantal Dean, who pulled this all together and did all the work organizing all of you. She is truly the dragon lady in the president's office, but she's got a very nice demeanor. So she's fabulous. Alex and Kim and Jason and Joseph for their technological support, and our entire team at NOSM University. It's my dream team, guys, and it is made up of family docs. A lot of us in leadership, but we work collaboratively in a great team spirit. So I hope you guys had a great time. It's the 1st of February. I will remind you that it's Black History Month. So, keep that in mind. And as we'll close, remind you that we are on the territory of First Nations and Métis people, and we're so happy to be here in Northern Ontario. Thanks, everybody. And if the panelists want to stay on for a debrief, please do. Amazing. Great turnout. I think we had about 115 people in total at the peak of the presentations. Good night, everybody.